Greetings and welcome to session 3 of the Lurie Children's Heart Center Preventative Cardiology Roundtable Series. This is number 3 in the series, and my name is Chad Worley. I'm your moderator today. I'm the physician liaison for Lurie Children's in the north side of the city, north suburbs, and northwest suburbs. And we are here with Dr. Kendra Ward. She's going to talk to us today about exercise and exercise therapeutics in pediatric heart disease. Dr. Ward is the director of Cardiopulmonary Exercise Lab. She's also the director of the Cardiac Rehabilitation Program. And she's also the director of the Preventive Cardiology Program, which you're going to hear a little bit about today. Welcome, Dr. Ward. Thank you for joining us today.
Thank you for having me.
You have an exciting topic. I think a lot of us out there are exercise regularly, so I'm sure we're going to hear some stuff that's fun to talk about. I know I work out every day, so I love to hear how is this helping my heart? So it's going to be exciting. And how is this going to help the kids' hearts, right? That's the most important part.
Exactly. Well, all of our hearts, right?
Yes, exactly. Dr. Ward, before we get started, as I mentioned, you're director of several of our programs here at Lurie Children's. Where are your clinics at? Can you tell us where you practice out of?
So I see patients at the main hospital downtown. I also see patients at our Northbrook location and our Arlington Heights location, soon to be our Schaumburg location.
Okay, great. Well, at the end of the presentation, I'll give everybody information how to refer into Dr. Ward and the program. But without further ado, why don't you go ahead and take it away? Oh, quick reminder. There are no CME credits for this program, but this is recorded, and we will be sharing with you. And please, we really encourage questions at the end of the program. So type them in the Q&A section, and if we have enough people today, or we can ask questions live. So you can raise your hand, but we really do encourage questions. So without further ado, thank you, Dr. Ward.
All right. Thank you, Chad. Okay, so I'm going to talk to you today about a topic that's really important to me, exercise and exercise therapeutics in pediatric heart disease. I will discuss why exercise can prevent and help treat pediatric heart disease and provide some examples in pediatric cardiometabolic disease, POTS, and congenital heart disease. If I have time, I will also cover a pilot study we just completed that focused on a different kind of exercise, voice lesson-based breathing exercises. We have been in a global epidemic of inactivity for over 15 years now. Physical inactivity is the 4th leading risk factor for death worldwide, and this is spread across income brackets. Lower fitness is associated with higher death rates. And a low level of cardiorespiratory fitness exposes an individual to a greater risk of dying than obesity, smoking, hypertension, diabetes, or high cholesterol. There are many benefits of physical activity and exercise for pediatric patients, ranging from improved attention and decreased depression to increased bone strength and improved cardiometabolic health. In this talk, I will focus on these changes that affect primarily cardiovascular and cardiometabolic health. Exercise results in improved cardiovascular health by many pathways. For example, exercise improves oxygen delivery, increases mitochondrial biogenesis, and has a long-term anti-inflammatory effect. These effects are likely mediated by exerkines, including exerkines released from muscle cells called myokines. To date, over 300 exerkines have been identified. Exercise-induced myokines mediate organ crosstalk and improve cardiometabolic health. Myokines are exerkines that are released from muscle cells, and this slide describes the roles of 4 different myokines in improving insulin sensitivity, decreasing inflammation, and enhancing revascularization, among many other functions. Exerkines are likely carried in extracellular vesicles, which we call EVs because it's easier to say, that act as cargo carriers or mediators of intercellular communication. This slide shows EVs pinching off from cells and starting to carry their important exocrine cargo. This is a schematic of the origin, release, composition, and cargo of EVs following an exercise stimulus. A variety of cellular signals are activated by exercise in heart muscle cells, or cardiomyocytes, and the systemic environment, and are delivered to the cardiomyocyte by EVs to orchestrate a complex cascade of genomic, metabolic, and functional events that ultimately lead to improved cardiomyocyte contractility, cardiomyocyte hypertrophy in a healthy heart, or reverse remodeling in a failing cardiomyocyte. Given exercise-related health benefits, the physical activity guidelines for Americans had these recommendations for pediatric patients: at least 3 hours of physical activity daily for 3 to 5-year-olds, or 15 minutes for each hour that they are awake, and a minimum of 60 minutes a day, 7 days a week of moderate to vigorous physical activity, plus muscle and bone strengthening exercises for all 6 to 17-year-olds. So what do we know about exercise and exercise therapeutics for patients traditionally followed in pediatric preventive cardiology? In pediatric preventive cardiology, we tend to see patients who have abnormal lipid panels, elevated blood pressure, and those who have obesity with additional cardiometabolic risk factors. Exercise is an important therapy for all of these diseases and risk factors. Although there are varied results throughout the literature about the impact of exercise on the lipid panel, the general consensus is that HDL and triglyceride levels are more sensitive to aerobic exercise than LDL, resulting in increased HDL, lowered triglyceride, and some small decrease in LDL cholesterol. We do know that familial hypercholesterolemia mortality risk is significantly reduced with statin therapy plus aerobic exercise compared to either alone. I'm getting a bunch of notifications on my screen here. I'm just going to click out of those.
It's all good, Dr. Ward. It's just people typing in on the chat room.
Sounds good. There are pediatric studies also looking at this, which have similar results to the larger adult studies. And these studies have also shown that children who have lower cardiorespiratory fitness also have higher total cholesterol and lower HDL cholesterol compared to children who have higher cardiorespiratory fitness. Moving forward. Sure what's happening. We'll try that. How's that? There's a strong association between hypertension and cardiovascular disease. Each increase of 20 millimeters of mercury in the systolic blood pressure or 10 millimeters of mercury in the diastolic blood pressure doubles the risk for an acute heart attack or an ischemic stroke. Blood pressure regulation occurs via interactions between the nervous system, endocrine system, cardiovascular, and renal systems. Disruption in any of these systems can cause hypertension. Furthermore, chronic hypertension leads to dysregulation of all of these symptoms, resulting in a vicious cycle of worsening hypertension. Exercise is considered a key factor in the prevention of and management of hypertension. There are acute, subacute, and chronic blood pressure responses to exercise. With acute exercise, a healthy individual will have an increase in their systolic blood pressure and either maintenance of or a decrease in their diastolic blood pressure. However, a patient with hypertension might actually have an exaggerated blood pressure response to exercise, and we think that this portends higher risk of significant cardiovascular maladaptive responses to hypertension. The subacute response of a drop in blood pressure following exercise can be helpful in management of hypertension, and lasts on average about 12 and a half hours. There is a dose response pattern, so longer or more intense exercise can actually result in a drop in blood pressure for up to 19 hours. And chronic exposure to exercise results in long-term decreases in blood pressure. In fact, this meta-analysis compared exercise to antihypertensives for the treatment of hypertension and found that exercise and hypertensive medications were at least equally effective in preventing the sequelae of hypertension, with exercise at times more effective. And this is exercise alone, not exercise combined with medications. Studies evaluating children with hypertension show that physical activity results in a reduction in both the systolic and diastolic blood pressure. And the literature suggests that children might need less exercise than adults to achieve these results. The vascular endothelium, which is located in the intimal portion of the vascular wall, secretes many vasoactive molecules that are involved in regulating coagulation, inflammation, and vascular remodeling. Indeed, impaired endothelial cell function is critical in the pathophysiology of atherogenesis. Endothelial dysfunction is strongly associated with hypertension, and improvements in endothelial function are associated with significant risk reduction for cardiovascular outcomes. Sedentary behavior is associated with impaired endothelial function. Luckily, exercise improves endothelial function and is considered first-line therapy for vascular dysfunction. The improvement in endothelial function may not be as significant for those who have very long-standing hypertension, which is all the more reason, in my opinion, to start exercise early in our pediatric patients. Studies evaluating the effect of exercise on childhood obesity have varied structure and results. Despite these shortcomings, though, the literature supports exercise as a necessary intervention for management of childhood obesity. In the HEART-E trial, there were modest but statistically significant reductions in body fat and waist circumference in subjects who did either aerobic or resistance training without any real difference between the two. So in summary, there are many, many, many cardiovascular improvements related to exercise. Because of all the exercise-related cardiovascular benefits, we embedded an exercise physiologist into our preventive cardiology clinics. This graphic demonstrates the flow of a preventive cardiology clinic visit and how the exercise component is part of each preventive cardiology clinic visit. This slide outlines the goal of our pediatric preventive cardiology exercise program. We aim to meet families where they are and create a personalized program that meets their needs, utilizes the resources that are available to them in their home and their community, and ultimately becomes an enjoyable part of their lifestyle changes that have been recommended by their clinic providers. The Preventive Cardiology Exercise Program is a 6-month program that's designed to start with a lot of support with a gradual transition to patient autonomy. When a family checks in to preventive cardiology for the first time, this brochure is provided describing our exercise program. Pivoting now, what do we know about exercise and exercise therapeutics for pediatric patients with POTS? Patients with POTS often present to us with cardiovascular deconditioning, cardiac atrophy, and hypovolemia. Their small hearts and reduced blood volume result in a large fall in stroke volume during orthostasis that then results in an excessive increase in heart rate via the baroreflex, which we call reflex tachycardia. This combination of factors results in significant limitations to even low-intensity physical activity. Complicating factors is that the very activity that is so challenging for patients with POTS, exercise, is a cornerstone of their treatment. This is a study that we did looking at cardiopulmonary exercise results for patients with POTS compared to age and sex matched normal controls. And you'll see that the blue line is POTS and the blue bar is POTS and the yellow is control. The green is patients who presented to our POTS clinic with orthostatic intolerance but didn't technically meet the criteria for POTS. And you can see their results are very similar to those with POTS. And we found there was a significant difference for several exercise variables, including stroke volume, exercise and aerobic capacity, and heart rate. This reinforced our goal for including structured exercise training for all patients seen in our POTS program. And similar to the Preventive, this graphic shows how exercise consultation, prescription, and supervised exercise therapeutics are incorporated into our POTS program. Our current program consists of both cardiovascular and resistance training, with gradual increases in volume and intensity of each over time. Cardiovascular bouts are initially short, with small additions of time each week until intervals can be introduced. Similarly, resistance training advances from supine to seated to standing and ultimately to gym-based workouts. So what about exercise and exercise therapeutics for patients with congenital heart disease? There was a great American Heart Association scientific statement that was put out in 2013 that has a lot of information about counseling for patients with congenital heart disease. I think one of the most important points of this paper was that most children with congenital heart disease can and should follow age-appropriate physical activity guidelines. There are, of course, complex congenital patients and arrhythmia patients and some others who will need modifications, but overall, the recommendations are for similar exercise time and activities as patients who don't have congenital heart disease. We know that most children with congenital heart disease do not meet the recommended levels of physical activity, and when they do, they tend to choose less vigorous activities or sports compared to their peers who don't have congenital heart disease. We also know our patients with congenital heart disease have low levels of physical activity-related self-efficacy, which improves when they exercise more. They also have anxiety related to exercise and sometimes interpret normal symptoms of exercise, such as an increased heart rate, as a pathologic outcome from their exercise. Both patients and their parents are confused about exercise recommendations that they receive from their cardiologist, with a third of parents of unrestricted patients reporting that their child was restricted by the cardiologist. Indeed, parents and children want very specific information and recommendations and don't appreciate the general statements that we put in our notes, such as physical activity is recommended or limit related to symptoms. And this is something that I have been guilty of in the past as well. This is a graphic from a recent American Heart Association scientific statement. And you will see that I changed part of this graphic that's to say observed peak VO2. And in the original paper, it said expected peak VO2. And peak VO2 is oxygen consumption, which is considered the gold standard of measuring cardiorespiratory fitness. And we measure this during a cardiopulmonary exercise test. And this graphic shows that patients with congenital heart disease have significantly lower cardiorespiratory fitness. This is from a paper looking at adults with congenital heart disease, and I dropped this red line in to show where normal fitness is, and you can see that most adults with congenital heart disease fall well below that. When we look at children with congenital heart disease, again, I dropped the red line in normal. They actually appear to be similarly distributed to kids who don't have heart disease, with the exception of our single ventricles. And this is similar in the data that I looked at in our pediatric congenital heart disease patients from our lab. So what happens between childhood and adulthood? Why does our patient's fitness drop? This is due to a complex combination of fear of exercise, decreased muscle mass, cardiac dysfunction, arrhythmias and chronotropic incompetence, and also lung disease. Interestingly, almost all of these things that result in decreased exercise capacity can be fixed by exercising. Studies that look at this agree that patients get significant improvements in their fitness levels and their daily functional capacity from exercise. And this meta-analysis compared medications for Fontan patients to exercise. And you'll see here that exercise resulted in significant improvements in cardiorespiratory fitness, much more so than medications. And other studies have shown the same, an improvement in VO2 peak or fitness, but also an improvement in lung function with improved FEV1 and FVC. So as a general pediatrician, what should you do for these patients? I think it's important to know the recommendations from their primary cardiologist, and if it's not clear, to seek more information from the cardiologist. Assessing the current physical activity level of your patient is important, and reinforcing the importance of routine exercise, specifically for their long-term health, for their congenital heart disease, is helpful. We have a lot of services in Lurie cardiology. Patients can be referred for exercise consultation and prescription. They can be referred to cardiac rehabilitation and cardiac fitness programs. And we do this as for inpatients, outpatients, and we have a hybrid program that incorporates telehealth. So patients don't always have to come to Lurie for all of their services. And we also have a variety of different exercise tests that are available for symptomatic patients. And if you're not sure, just give me a call. I love this topic and I love to promote exercise for our patients. So I'm always happy to talk about it. So quickly, I'm going to cover a different kind of exercise, breathing exercises for the patient with Fontan circulation. So patients with Fontan circulation do not have a subpulmonary pumping chamber, meaning that there isn't a heart chamber that pumps blood to the lungs. So they are reliant on having healthy lungs with a low pulmonary vascular resistance, as well as negative intrathoracic pressure and kinetic and pressure changes related to ventricular contraction and relaxation for blood flow into their lungs. But a lot of the things that we do to patients who have Fontans and things related to their primary heart disease result in them not having healthy lungs. So we have learned over time that negative pressure ventilation works better than traditional ventilation strategies for a lot of patients, but especially for our patients with Fontan circulation. We have learned that pulmonary vasodilators improve functional capacity for patients with Fontan circulation. And there have been some interesting studies looking at controlled respiratory training or breathing exercises and found that these are helpful for functional capacity as well. So we thought, how might we achieve something like this for our young patients who have Fontan circulation? Who do we know who have the best lung mechanics? Well, what about patients who are in a choir? And we came up with the idea, primarily this was led by Dr. Andy Pellick, but a large group of us worked on this, both at Lurie and at the Northwestern School of Music, of the Fontan Choir singing as therapy. And we launched our pilot feasibility study in September of 2024. And these are some slides of some of the testing that we did both pre and post our sessions. The patients attended sessions for 8 weeks every Wednesday evening for 2 hours. They had individual voice lessons, and then they had choir sessions singing with other children who have Fontan circulation, and they had daily homework all aim to improve their lung function. Again, some more pictures of some of our testing and some of our individual singing lessons. You will see not only our patients here, but Nancy Gustafson, who is a retired, very famous opera singer who worked one-on-one with our patients, which was pretty amazing. And we culminated this study with a performance by all of the kids in the Fontan choir. I had the great opportunity of working with just so many amazing people on this project, and we are currently in the process of recruiting for a multi-center Fontan choir trial. Thank you so much, and I'm open for any questions you may have right now.
Thank you. How fun is that Fontan choir? That is just great.
It was amazing. I spent every Wednesday evening with these patients, and it was hands down the highlight of my year.
I could only imagine how great that must have been. We at Lurie actually have some video of that we can share with the audience if you guys, if anybody's interested. And I will be sure to post that, repost that again on social media for everyone to see, because it gives you all the good feels when you see that video. So pictures are great, but the video is unbelievable. So I'll be sure to share that with everybody in the audience. So what a great presentation. So thank you for that.
Thank you. Thank you.
We have some questions coming in. Let me just start with a question that came in twice. Even if a patient, POTS or CHD aside, when should a patient be referred into the Preventive Cardiology Program at Lurie Children's?
That's a great question. So anytime that there's an abnormal lipid panel, those patients should be referred to us in pediatric preventive cardiology. Even the younger patients, we sometimes have patients who have a family history of familial hypercholesterolemia and are referred to us as early as age 3 or 4. And while we won't necessarily start medications.
Sorry about that, everybody. Go ahead. My apologies.
No worries. So even for those younger patients for whom we wouldn't necessarily start medications, we start to reinforce all of the life essential 8 that you heard about yesterday from Dr. Marma, the healthy lifestyle and diet recommendations for the patient. And also sometimes this helps us identify adult members of the family who also should be seen by cardiologists. Any patient who has elevated blood pressure without kidney disease can be referred to preventive cardiology, especially if the sort of usual approaches are not working. Any patient with obesity who has additional cardiometabolic risk factors, we are happy to see them. And if there's a history of early death related to atherosclerosis, myocardial infarction, early stroke, we are always happy to see those patients because, again, starting these early lifestyle changes is going to be more impactful at making them last lifelong. And the earlier we start to improve the cardiometabolic risk factors for patients, the better their long-term health will be.
Okay. Thank you for that. So some other questions that have come in regarding exercise. What is considered moderate to vigorous? Is it heart rate activity? Is it just, it's such a wide range of like, this is what it is, right? So could you maybe expand a little bit on like what we should know?
Yeah, so that's always a tough one to define. When you look at the American College of Sports Medicine, they have defined moderate exercise as a level of exercise where you can say words and maybe talk a little bit, but you certainly couldn't sing or hold a full conversation. And you should feel a little bit short of breath. Vigorous exercise is you can't really talk, you can't really hold a conversation, and you should feel sweaty and breathless.
Okay. So some more here. Does the type of exercise matter? So, anabolic versus aerobic activity, anabolic more like weightlifting and probably like yoga compared to running and sports like basketball or something like that. As long as they're moving, that's what we're really concerned about, right? Or is that or am I being too generic with that?
No, I don't think you are. Most of the early studies were done with aerobic exercise or endurance training or those types of exercise. And some of the early studies suggested that aerobic exercise was better for control of elevated blood pressure than resistance training. But there have been some more recent studies that have brought that into question. And it actually seems that what matters is that you're moving. We like the combination of all of them for kids because they have different impacts. So, you probably get more improvement in your endothelial function from aerobic exercise, but resistance training improves your muscle strength, which also improves some of your cardiometabolic markers
Right.
and your insulin or your glucose utilization
Mm-hmm.
and decreases the risk of insulin resistance. And we like exercise that can improve bone strength and muscle strength because childhood is when you build those.
Yep. So the question then is, I hear this all the time from people, and I'm sure you do too. Well, I eat right. So do I really need to exercise or the other way around, right? I exercise all the time, so it doesn't matter what I eat. And I'm a kid, I have a high metabolism. It doesn't matter what I eat. Let's talk about that for a second, right? Because I mean, I feel like it shouldn't be one or the other. You do need both. Okay, kids need to eat healthy to go along with exercise.
Yeah, and I think probably our talk by Dr. Marma really highlighted that, looking at life's
Yeah.
essential eight.
Hmm.
Um, and the reason that those eight behaviors and physical findings are included in the American Heart Association recommendations is because they're all important. And the more of those factors that kids are doing or adults are doing, the healthier they're going to be, not just from a cardiovascular or cardiometabolic standpoint, but also things like decreasing the risk of cancer and decreasing the risk of Alzheimer's. All of those things are important. And the more of them that you do, the better your overall health will be.
Uh, so how many days your kid be exercising? 5 days, 3 days, 6 days, seven?
Seven. Seven.
I say seven, right? Yeah, that's what I say. Get out, get off the couch and get out there, right?
Yeah, I mean, the current recommendations from the AAP, the AHA, the CDC for kids between the ages of 6 and 17 is 7 days a week. Um, there's small variations for younger kids, but in general, the even younger than that, they actually recommend 3 hours a day, and for infants, at least 30 minutes of tummy time a day.
Hmm.
But in general, for most of the kids we care for, we're looking at a minimum of 60 minutes, 7 days a week. Now, could somebody do 3 hours one day and have a day off? They could. Kids sometimes overestimate how much exercise they're actually doing.
Hmm.
They may have a 3 hour baseball practice, but they may actually only be doing 30 minutes of moderate to vigorous physical activity during that time.
Yeah,
Um,
as a baseball coach, I get that. Yeah, that's I want to segue because you brought something up. I want to segue into one of our last questions here. In your slides, uh, you mentioned lack parents' frustration of lack of information. With that said, do we or is there handouts available that we can provide our pediatricians, whether it's through our website or through another website, or digital handouts, such as the brochure you handed out that we can provide. And I say we as myself and Paula Nowak, the liaison in the south suburbs, and Julie Kalkbrenner, the liaison in the west suburbs, that we can share with the practices or with our folks on social media to get some of this information that's very important for parents to know.
Yes. There are several different things that we have available. We have created several different infographics or handouts for our patients in our Preventive Cardiology Program, in our POTS program, and for our patients who come for exercise consultation and prescription. We are initiating a physical activity vital sign program. And with that, we've created several different handouts that will have QR codes available that based on what your physical activity vital sign actually is, there will be different information available for patients and families of how to improve the amount of physical activity that they are doing and ways to be active if you need to be inside, can't go outside, if it's not safe to go outside, if you don't have access to a gym. We will have all of those different handouts available.
That's outstanding. Thank you so much. So we need to wrap things up here. So for those of you who are interested in those flyers, those links to websites, you can email your liaison. You can, if you're watching this recording, well, first hit like if you're watching this recording. And number two, just let us know that you're interested in the comment section, and we can provide a link for you and send it your way. And if you need to refer into the Preventive Cardiology Program here at Lurie Children's, you'll see here on the screen, families can call 1-800-KIDS-DOC. You can also use your MyChart to refer into. We definitely encourage that. Physicians, call in at 1-855-LURIE-MD. You could also go to Lurie Children /find-a-doc to find Dr. Ward. You can refer into her directly. The other thing we can do is I ask you to, and I encourage everyone watching this video, is to bookmark or scan the QR code here. This here is our online referral toolkit that gets you all the information that you could possibly need out of Lurie Children's. It takes you right to our physician services webpage, and we have all of the referral information. We have phone numbers, locations. They'll tell you where Dr. Ward is at, and you can ask her questions there. Patient referral forms, laboratory recs, has all that information there. So I encourage that. Dr. Ward, thank you again for joining us today.
Thank you for having me. It was really a joy to talk about this topic.
It's a wonderful topic. And then we encourage everybody to join us at 12 o'clock for session 4 for Dr. Batista's lecture on lipids and lipid screening. So that should be another fun tool for everyone to use. But that said, we're going to wrap it up. And thank you for joining us today, and have a great afternoon.